Hello, I am Dr. April Pruski, and I am an assistant professor in the PM&R department at Johns Hopkins. I am also the medical director of the PM&R consultation service line. Today, Annette and I are going to be talking about the Acute Hospital Rehabilitation Intensive Service model of care in stroke.
Hi, I'm Annette Laveza. I'm an assistant professor of PM&R and the director of inpatient therapy services at Johns Hopkins Hospital. And I'll be have the pleasure of joining April for our discussion today. We'll start with that we have no financial disclosures. And then let's jump to a definition of what the Acute Hospital Rehabilitation Intensive Service is. We refer to that as ARISE or ARISE. It is a program that we created at Hopkins for targeted patient populations so that they can receive higher intensity therapy in the acute hospital setting. Our traditional models of therapy have focused on providing an evaluation and moving patients to the next level of care, and have left little opportunity for us to be able to provide intervention while a patient is in the acute care setting. We designed the program and initiated it with several populations, and we used it with our liver transplant patients. We used it during the initial waves of COVID, as well as with stroke. And so we're really focused on coordinated early rehabilitation care outside of the rehabilitation unit. So as early as in the ICU, but also on the floors. So coordinated physiatry care, rehab medical management, coordination with the therapy teams, medical teams, and care management teams. And then therapist interventions focusing both on impairment remediation and compensation in an effort to improve patients' function before they're discharged, rather than just focusing on moving them to the place where those activities would start later in the course of care. So in stroke, our goal is to evaluate and treat patients with a wide range of deficits that are post-stroke related, and to identify for them appropriate follow-up to return to independent living. So all patients with new strokes who are admitted to neurology at the Johns Hopkins Hospital are included in the program. They receive PT, OT, and SLP consultations based on the lesion and their impairments, and they also all receive a PM&R consult. And we're going to go into more detail about what each of these groups offers. So there are two pillars of ARISE. The first pillar is an enhanced therapy model, and the second pillar relates to rehabilitation huddles. So we're going to break these down a little bit and talk about each of them and the impact that it has on patients. So our traditional model of acute care, as I talked about before, is that we are really looking at consultation for discharge recommendation. We're focused on moving them to the next level, and there's really limited focus on intervention. And so what we have deployed with ARISE is this model of shorter, more frequent therapy sessions. So why did we choose shorter, more frequent therapy sessions? Well, we based that on data from the results from the AVERT trial in 2016, which suggested that shorter, more frequent sessions per day could improve the chance of regaining independence after stroke when they controlled for age and severity. So for example, 10-minute interventions 10 times a day suggested a more favorable outcome than longer, more intense, less frequent therapy sessions. And so based on that information, we have set up a structured model for how we provide therapy for our ARISE patients in stroke. So our enhanced therapy model includes PT, OT, and SLP, and we provide daily intervention for our patients. One of the very unique things about what we do for our ARISE patients and our stroke patients is that we are staffed equally for PT, OT, and speech, and that is not the case for other areas in the acute care hospital. That gives us bench strength and the ability to provide the enhanced therapy because we have equal numbers of therapists for each discipline. Ideally, we're seeing patients on weekdays who are medically appropriate 2 times a day for each discipline. PT twice, OT twice, speech twice. On weekends, they get daily therapy, but it's alternated between disciplines. So let's talk about what happens in those sessions, because I think this is an important focus of what we do. So we've asked the therapists to really think about their sessions and use one of those sessions as a session that's more focused on compensation and another session that is more focused on remediation. And so when we think about how we've cared for our stroke patients in the past, a lion's share of what we've done is focused on compensation. We have really talked about what do we need to put in place, what adaptive equipment do we need, what environmental changes do we need just to get them moved to the next level of care. And while that's important, and we need to think about how do we help patients do basic activities. So if I'm unable to feed myself and you need to give me a modification to help me be able to feed, that's important. The challenge is that it doesn't help me regain my skills. It doesn't support the principles of neurorehabilitation and doesn't necessarily restore my function. It teaches me compensatory strategies. And that model of compensation is really often considered, or sometimes considered, sort of what you would do if there isn't hope for recovery. And with our stroke patients, we really hope there's recovery. So in that compensatory session, we might be focused on how do I use an adaptive device so that I can feed myself, right? Because that's important. I need to be able to do that to be able to go home. But then my second session of the day really needs to look at remediation. So how do I take those principles of neurorehabilitation and mass practice and movement patterns and work with that patient so that they can develop more normalized movement patterns so that they can feed themselves without that adaptive equipment at some point in their recovery. And so we want to split out what happens in those two sessions. The next pillar of the ARISE program is really our rehabilitation huddle. So we talked about how this was a collaborative approach between therapy and physiatry. And so our goal is to really have one unified rehab plan and improve the disposition guidance for that patient so that they can continue in their recovery as they move forward. And that one unified rehab plan is really key. I think it is challenging for our care management partners if each of the disciplines is presenting a different discharge disposition and they are asked to figure that out. Or there isn't medical management of components of their recovery that would really help them progress. And so the stroke huddle is scheduled daily, Monday through Friday. Everyone is present, the people on the team who is working that day, physiatry and the therapists who are working that day. Each of the disciplines provides an update. So there's a current functional status report. Is the patient improving? Are they plateauing? Are they declining? How are they functioning? What are the barriers to continued progression? Physiatry helps us with potential pharmacologic interventions for spasticity, depression, cognition, pieces that as therapists, we may not consider as closely. And so it's really helpful to have that added layer of information, and then need for any additional consultations. And so each patient is we go through the list for each patient each day, and then that information can then be fed back to the teams and the care management teams, and we are then a cohesive rehabilitation approach to what we're doing with patients.
Thank you, Annette. Next, we're going to be looking at the Johns Hopkins affiliates to further describe what this change to the stroke rehabilitation model looked like. The ARISE stroke model of care at Johns Hopkins began January of 2019. We will be looking at a 6-month time from stroke discharges from June 1st, 2019 to December 31st of 2019. Looking at the stroke care at the Johns Hopkins Hospital and its affiliates, we can see that the most discharges come from JHH, or Johns Hopkins Hospital, and BMC, or Bayview Medical Center, followed by HCGH, or Howard County Hospital, then SUB, or Suburban Hospital, and lastly at SIB, or Sibley Hospital. We have physiatry services at both Bayview Medical Center, and the Johns Hopkins Hospital. The ARISE program is specifically at Johns Hopkins Hospital, where 92% of stroke discharges received therapy visits. Given that these two hospitals are both comprehensive stroke centers with similar number of stroke discharges, we'll be comparing these two medical centers in the next few slides. Looking at the average length of stay, we can see that both Johns Hopkins Hospital and Bayview Medical Center each have comparable median length of stay of 5 days, which is longer than the other community affiliate hospitals of Howard County, Sibley, and Suburban. The average length of stay at Bayview is slightly lower at 7.9 days compared with Johns Hopkins Hospital, which is 8.1 days. Looking at the therapy total visits, there is a significantly increased amount of therapy given at Johns Hopkins Hospital of 5,382 visits compared to Bayview's 1,708 visits. Patients at the Johns Hopkins Hospital service received approximately 3 times more therapy visits as compared with Bayview. Looking at the bar graphs, green is occupational therapy, gray is physical therapy, and blue is speech language pathology. There is a more even amount of PT and OT and SLP given in the total number of visits at Johns Hopkins Hospital, as Annette mentioned previously, as compared with Bayview, which you can see provides less speech language pathology services to patients. Looking at the physiatry visits, only 27% of stroke patients were seen by a PM&R specialist at Bayview Medical Center, while at Johns Hopkins Hospital, 57% of patients were seen by a physiatrist. Looking further into the physiatry visits, patients at Johns Hopkins Hospital had approximately 4 times more visits than patients at the Bayview Medical Center. Of the patients seen, on average at Johns Hopkins Hospital, patients were seen 3 times, while patients at Bayview were seen twice. At Johns Hopkins, 1 patient was seen 10 times during their acute stroke stay, and at Bayview, the maximum physiatry follow-up was 4 visits. Now, looking at the discharge dispositions, the orange and yellow represent discharge to post-acute care. The orange represents discharge to subacute rehabilitation, while the yellow represents acute rehabilitation. At Bayview, 27.5% of patients were discharged to subacute rehab, while only 14.1% of patients were discharged to subacute rehab at the Johns Hopkins Hospital. More patients were sent to acute rehabilitation at Johns Hopkins than at Bayview. The green represents home. Over half the patients in this timeframe were discharged from Johns Hopkins Hospital to home, as compared to 39.3% of patients discharged from Bayview. In conclusion, the Acute Hospital Rehabilitation Program is a model of care that provides rehabilitation in the acute hospital outside of the traditional rehab unit. The ARISE program has the potential to direct rehabilitation services to the right patient at the right time. While we can see that at the Johns Hopkins Hospital, stroke patients received increased amounts of therapy with comparable lengths of stay compared to its affiliate of Bayview Medical Center, we do not yet understand what the long-term implications of the ARISE model are. We will need further analysis to understand if ARISE can impact length of stay, total cost of care, decrease long-term disability, and improve a patient's hospital experience. Thank you for your attention to our presentation.